role has changed from a mere dispenser. So you are now a counselor. Follow the 8 rights of medication administration and care for the patient. So, what are the 8 rights of some problem with the screen? It is not moving. Can you hear me?
You can de-share and again reshare.
Yes, sir.
Yeah. Okay. Okay. No, again, there is a problem.
Is it okay, sir?
No, it is not moving. Wait 1 minute.
Sir, don't go to the presentation window, sir.
So, madam, you can get the copy and you can run the presentation if possible.
Right. Yeah.
Sir, keep this mode only, sir. Don't go to the presentation mode. Sometimes it gives problem.
Okay. Okay. Shall I go to this mode? Okay.
Yes.
All
Not
right.
a problem.
Is this okay?
Yeah.
All right. So we come to 8 rights. Can you see this clearly?
Yes, sir. Properly.
Okay. So 8 rights include patient's name, drug name, dose, time of the day to be taken, right route, right reason, right documentation, and right response. So these are the 8 rights which you have to follow while dispensing. All these are clear by themselves, except documentation means you have to document the actual item given to the patient very, very clearly on the packet. If there are multiple packets you're handing over, what is there in each packet should be documented. And response is very important. If the same patient comes to you for same medication again and again, then you have to really go and ask him why exactly he wants the same medication again and again. What is the response? Is it really required to take? So that also is a very, very important role a pharmacist has to play. So what are the precautions to be taken while dispensing a prescription? Very, very important. Confirm that the prescription is legal, correct, and complete. Check for prescription errors. Beware of look-alike and sound-alike drugs. Observe for obvious drug interactions. Be careful with zeros and abbreviations. Distraction as much as possible and avoid any dispensing errors. So we go one by one. What are the situations most likely to contribute to an error in a pharmacy? Experience. There might be certain pharmacies who have just joined. Any pharmacist who have just joined a pharmacy has lack of experience, so more likelihood of contributing to an error. Rushing. Don't be a man who just rushes to get the drugs. Look at the drug, double check, and only then dispense. Doing 2 things at once. Interruptions. Suddenly when you're dispensing, if you get a phone call from your wife, stop, take the call, but again, go back to the prescription. Say that you dispensed the correct prescription. Fatigue, boredom, at the end of the day, more chances of getting it wrong. Lack of checking and double checking habits. Always nice to check and double check. Poor teamwork and communication between colleagues. If you have doubt about a prescription, you have to check it with your colleague in the pharmacy. He may understand handwriting better, because some doctors have very beautiful handwriting, so nobody can read. So it's always better to clarify the drug before dispensing a wrong one. Reluctance to use memory aids. So these are the situations most likely to contribute to an error. Now coming to a prescription. What is a prescription? It is a written order by the treating doctor to the pharmacist for dispensing the drug or drugs to the specific patient. It is a written medical legal document by an authorized person for the treatment of the patient and is a reflection of the quality of healthcare service being delivered to the patient. So it goes without saying, it is a skill acquired through training. So as Professor Avery has very beautifully put it, prescribing is a skill, and it is one that all doctors should take time to develop and keep up to date. But unfortunately, this is not happening. This is an ideal prescription. These are the various parts of the prescription. There should be the date, very, very important, name of the patient, age, and maybe the weight. Then there is take thou, there is you take, whatever I write, superscription. Then the actual inscription, say paracetamol 500 milligrams. How many tablets? That will be subscription. What is the dose, BID for 5 days or TDS for 10 days, whatever it is, that is signatura. And very, very important, signature of the doctor, registration number and seal. So unless the prescription is signed, it is not valid. So there has to be a date, there has to be a signature, there has to be registration number also, and only then the prescription is valid. So if you get a prescription where something is just written on a piece of paper without a sign, without a registration number, then it is an invalid prescription. Do not handle it and do not dispense that prescription. Such prescription should not be honored. What is a prescription audit? Now, this word is a vastly useful word. It has a lot of meanings in medicine. It's a part of the holistic clinical audit and is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria and the implementation of change. Don't bother about this complicated definition. What you should understand is that it is an educational activity, and if regularly done, it can aid in improving the prescription quality and can help the patient to receive high standard and best quality care. And it can definitely be a part of regular dispensing. So if you develop habit of prescription audit in your pharmacy as a part of regular dispensing, it can definitely be a very good educational activity, and it can definitely improve your standard of dispensing. So what are the audit parameters? These are the points you will consider before you dispense, whether all these things are there in the prescription, whether yes or no. Name and age of the patient, the OPD number, dose of the drug in the dosage schedule, route of the drug, frequency and time of administration, date, legibility. This is very important, legibility, because there are so many names which are look alike, sound alike. We'll come to it a little later. So legibility is very important. Known allergy documentation. It is the responsibility of the doctor to write whether the patient is allergic to any particular compound or not. Prescription errors, if any. I will discuss a few prescription errors which can be easily spotted by a pharmacist. Then drug interactions, food drug interactions, if any, and signature of the doctor. So if you look at the prescription and try to analyze these parameters, that itself becomes an audit in the pharmacy while dispensing, and it can be very useful and helpful to improve your dispensing in the pharmacy. So coming to prescription errors in clinical practice. Now there can be hundreds of errors. Whatever errors I have mentioned are live errors which have actually happened in the prescriptions and committed by the doctors. So see, just to give you an idea, what are the level of errors that can be committed, and at your level, what can be picked up and how you can help the patient. All these errors you may not be able to spot when the prescription comes to you, but at least if you can see and observe some of the errors, then it will be a great help to the patient. So prescription errors may be defined as an incorrect drug selection for a patient, be it the dose, the strength, the route, the quantity, the indication, and the contraindications. So factors contributing to prescription errors, there are technical factors, we have indication errors, we have dosing errors, we have kinetic errors, and we have combination errors. And there are a lot of contributing factors like illegible handwriting, which can be error A, then verbal orders, sound alike, look alike drugs, stress, incorrect diagnosis, inaccurate history, decimal points, 5.0 if somebody writes, if that point is not seen, you may interpret it as 50. Abbreviations, many doctors write abbreviations. I may write CP's head or CB's head, what would the pharmacist interpret? If it is CBZ, it could be carbamazepine, it could be clobazam, it could be something else. So each pharmacist may interpret these abbreviations differently, and different drug may be given to the patient. So never entertain any prescription with abbreviations. Similarly, verbal orders are something which are never to be honored because sound alike drugs. A patient may say something, you may hear it as another thing, and a wrong drug may be given to the patient. Look at this prescription. Can you read this? This looks like Kannada more than English. So such prescriptions should never be honored. Send it back to the doctor. I know one case where a prescription, illegible prescription, was sent back to the doctor, and doctor himself could not read his own handwriting. So he asked the patient again, all over again, what is the history and what happened to him, so that he could write it all over again. So such things happen. So coming to indication errors, this can be of three types: underuse, overuse, and misuse. Underuse is the failure to provide a medical intervention when it is likely to produce a favorable outcome. All these you may not be able to pick up in a pharmacy, like failure to prescribe an ACE inhibitor or an angiotensin receptor blocker to prevent progression of diabetic nephropathy in a patient with diabetes, or failure to start artemisinin-based therapy in resistant falciparum malaria, or failure to initiate prophylactic therapy in a severe migraine patient. This could be, if you observe carefully, if a patient comes to you for migraine therapy again and again, then this could be one underuse indication error, failure to initiate prophylactic therapy to prevent frequent migraine attacks. So here you can help him. Overuse. Overuse can occur with unnecessary treatment. Many doctors just go on writing unnecessarily, like prescribing levofloxacin or moxifloxacin for uncomplicated bronchitis or pharyngitis of probably viral origin. If you just have fever and cough for 2 days, there is no need to prescribe levofloxacin or moxifloxacin for uncomplicated bronchitis. Many viral conditions can cause cough. So no point in giving an antibiotic which is effective only against bacteria and not against viruses. Or using antidepressants on an as-needed basis. If somebody's girlfriend has run away and he's depressed, he cannot go to the pharmacy and ask for antidepressants, and pharmacist cannot give him on an as-needed basis. Antidepressants take 3 months to start action, and they have to be taken at least for 6 months. Using antidepressants on an as-needed basis is not correct. Using corticosteroids routinely for rheumatoid arthritis, this can be easily picked up by a pharmacist. If you see a patient coming again and again to you for corticosteroids prescription, then you can ask him. This is what I said, 8 rights. Right response. You can ask him by way of response, why exactly he is being prescribed corticosteroids? What is the condition? So using corticosteroids routinely for rheumatoid arthritis is overuse, and it can cause a lot of adverse effects. Treating fever of few days with ofloxacin. Giving repeat prescriptions without keeping a count. People are following continue et al, city all, continue all, especially in hospital, same prescription is being continued every time. Now, giving these repeat prescriptions without keeping a count can be hazardous at times, especially when you are repeating prescription of, say, sedatives, hypnotics like alprazolam. People have been taking alprazolam for years together, and they have developed tolerance. So this is wrong. Using similar drugs or drugs with similar spectrum in a single prescription. Like I've seen prescription where tablet paracetamol was prescribed and tablet Sinarest was prescribed. Sinarest also contains paracetamol. So the doctor himself does not know what exactly he is prescribing. So here is the responsibility of pharmacist to pick up that this doctor has written paracetamol twice in his prescription. So let me clarify whether he has unknowingly done it or is there any other intention. So this is the role of the pharmacist in finding out a prescription error. Then overuse also occurs when unnecessary treatment is initiated for an unrecognized side effect resulting from current drug therapy. Like, for example, prescribing antihypertensives for patients whose high BP is a result of non-steroidal anti-inflammatory drug use. There are so many people, especially elderly, who has been prescribed NSAIDs for some joint problem, and they are continuously taking them, going to the pharmacy, asking for NSAID, pharmacist obliges. Unknowingly, this patient also takes antihypertensives. But this high BP is not his essential hypertension, but it is because of NSAIDs. So here you have to control NSAIDs and not prescribe antihypertensives for such patient. Initiating gout medications to treat mild hyperuricemia from thiazide diuretics. Now, thiazide diuretics can cause hyperuricemia, but you are not supposed to give allopurinol or colchicine for a patient with hyperuricemia from thiazide diuretics. It is a drug-induced hyperuricemia. Over-treating Parkinsonian symptoms from metoclopramide with levodopa. Metoclopramide can cause Parkinsonism, but it is not to be treated with levodopa. Failure to recognize pseudomembranous colitis during clindamycin therapy. Now, this is a complicated affair. If the patient has been prescribed clindamycin and he gets diarrhea, it could be because of pseudomembranous colitis which the patient has got as a side effect of clindamycin. So here you have to stop clindamycin. If this patient goes to the pharmacy asking for medicine for diarrhea, then you have to ask him whether he's taking any antibiotics, and that has caused diarrhea. So this is a very, very important role that a pharmacist can really play. Then misuse. Misuse refers to actions that result in preventable complications or wrong choice with no desirable effect. All these are live examples which have actually occurred in practice. Prescribing amoxicillin for a patient with a history of anaphylaxis to penicillin. So if the patient is allergic to penicillin, he cannot be prescribed amoxicillin. Or prescribing diazepam instead of zolpidem for those having difficulty falling asleep. If the patient has just difficulty falling asleep, once he falls asleep, then he can sleep for full night. Then the choice should be zolpidem, where the sleep is initiated within 5 minutes and the action lasts for 1 hour. So here diazepam is not the correct choice. Using long-acting beta agonists for acute bronchospasm. No, for acute bronchospasm, you have to use short-acting beta agonists like salbutamol or terbutaline, not salmeterol or bambuterol. Selecting ampicillin for prostatitis. Now, there are some doctors who write diagnosis on the prescription. So if the doctor has written prostatitis and prescribe ampicillin, then you can actually correct. You can discuss with the doctor. In foreign countries, pharmacists are considered better therapeuticians than some. You can pick up ampicillin does not enter prostate, so you cannot possibly prescribe ampicillin for prostate. Starting allopurinol in acute gout, this is a common mistake. Even the pharmacists, I've seen dispense allopurinol if somebody comes to the pharmacy to ask for treatment for acute gout. For acute gout, the treatment is either naproxen or etogicoxib or indomethacin 25 milligrams, not sustained treatment. But if you prescribe allopurinol, which is for chronic gout, to prevent acute gout in further attacks, then allopurinol can actually precipitate acute gout and condition can be worsened. So this is an important point to be noted. Starting allopurinol for acute gout can worsen the condition. Withdrawing beta blockers abruptly and replacing with other groups. So if you know a patient who has been on beta blockers for so many years and he has been coming to a pharmacy regularly, now suddenly he comes with some other drug. You can always ask him whether he has stopped beta blockers or whether the beta blocker is still continued and this is added to him. So you can always help him. Using nasal drops for more than 3 days. If you get a prescription for nasal drops, please tell the patient. I know it is a doctor's responsibility to tell this, but most of the doctors will not tell. So you can always tell because you are a link between the doctor. So you can always tell them not to use nasal drops for more than 3 days. So if you use nasal drops for more than 3 days, it can cause atrophic rhinitis. And this atrophic rhinitis can cause more problems than solution. Misuse can also occur when contraindication is unrecognized. Serum creatinine level exceeds 1.6 milligrams per dl. Or using inhibitors in pregnancy. Using tetracyclines in children less than 8 years. This is where you can pick up. If the age is mentioned in the prescription, less than 8 years, and somebody has prescribed tetracycline, then you can as well call the doctor and tell him, sir, I feel this is contraindicated in less than 8 years. Selecting venlafaxine for depression in children, it can cause suicidal tendencies. Prescribing quinolones in patients with epilepsy and psychiatric disorders, it can worsen epilepsy. Using diuretics for lithium-induced edema can worsen toxicity of lithium. And treating antibiotic-induced diarrhea with another antibiotic, again, is a misuse. Now, coming to dosing errors. This is very common. So first was indication errors. Now, the second type is dosing errors. There can be underdose, there can be overdose, there can be wrong dose or dosing pattern. So what is underdose? Underdose occurs when less than the recommended dose is given. Like prescribing antibiotics for less than 5 days, you can come across a prescription amoxicillin 4 tablets or 5 tablets. This is wrong. This is totally wrong. It will just increase the resistance to that antibiotic. So antibiotic should be given in the correct dose for at least 5 days. At least 5 days. So if there is a prescription where loose tablets are asked, capsule amoxicillin 500 milligram 5 tablets, so 5 capsules, then it is wrong prescription. Please call it and rectify it. Treating osteomyelitis with antibiotics for less than 4 weeks. Premature antidepressant dose reduction, as I said some time back, antidepressant should be given for months together. The action starts after 3 months and has to be continued for more than 9 months. Failure to prescribe adequate dose of antibiotic in an obese patient. If the patient is obese, 120 kg, your normal dose of antibiotic will not work. You will have to give higher dose of antibiotic to make up for his weight. Stopping pioglitazone before the action starts. Now, this is a very, very important thing. You may not be able to play much role here, but just for your information, pioglitazone is anti-diabetic where the action starts after 6 to 12 weeks. So doctor may feel, I already started pioglitazone, already 4 weeks have finished, 5 weeks have finished, 6 weeks have finished, and there's no response. But no, action starts only after 6 to 12 weeks. So it has to be continued before the action starts. Prescribing acyclovir 200 mg TDS in genital herpes. Please remember, acyclovir is one drug in pharmacology which has to be given 5 times daily. 5 times daily. It's the only drug which is given 5 times daily. So if you come across acyclovir where it is given TDS, it is wrong. So here in genital herpes, it is 200 milligrams 5 times daily, acyclovir. Recommending terbinafine 250 milligrams only for a week in onychomycosis. So fungal infection of fingernails, which is called as onychomycosis, is very, very rigid and resistant infection. It requires at least 6 months of terbinafine treatment. So if you find a prescription where terbinafine is prescribed only for 1 week, then it is wrong prescription. It is underdose. So you can be a very good counselor. Contact the doctor and ask him whether he has given with some reason, he wants to follow up after 1 week and then continue, or why for, whether he does not know. Don't ask him whether he does not know the dose. You can ask him nicely. Using colchicine 0.5 milligram TDS for a week in acute gout, again a wrong dose. It is 1 milligram immediately followed by 0.5 milligrams after 1 hour. That is the correct current dose of colchicine in acute gout. Overdose occurs when more than recommended dose is given. You must have come across so many prescriptions in your pharmacies where high dose is being prescribed wrongly. Like starting hydrochlorothiazide at a dose of 25 or 50 milligrams per day, even though 6.25 milligrams per day is often effective. So as low as 6.25 milligrams per day is effective. So starting at 25 milligrams or 50 milligrams is absolutely wrong habit. Prescribing metformin 1 gram and glimepiride 2 milligrams combination tedious. If I tell you metformin dose maximum is 2500 milligrams and glimepiride 4 milligrams, then you will understand how tedious can be wrong and overdose. So if you prescribe this combination tedious, it will mean that you have prescribed or doctor has prescribed 3000 milligrams of metformin, which is higher than the highest dose, and 6 milligrams of glimepiride, which is again higher than the highest dose. So here, these are good opportunities for you to be vigilant, to do prescription audit and correct the doctor. Recommending clomiphene citrate for inducing ovulation for more than 3 months. Again, a mistake. Clomiphene citrate has a rule of diminishing returns. It will be the best effective in first cycle, then second cycle, then third cycle. But after third cycle, the effectivity goes on decreasing. So there's no point in continuing clomiphene citrate for beyond 3 months. Prescribing azithromycin 500 milligrams once daily for more than 3 to 5 days. It is not like other antibiotics. Earlier, the dose was only for 3 days, but now the current guidelines, 2019 guidelines says, because of resistance coming up, you can give up to 5 days of azithromycin daily. Piroxicam 20 milligrams, etoricoxib to 120 milligrams is to be given OD. If somebody has prescribed BD or TDS, it is disaster. It can be very severely toxic to the stomach. Tadalafil 5 milligrams, the long-acting phosphodiesterase 5 inhibitor. For importance, it has to be given just once daily and not twice daily. You will be over-enthusiastic to do things, but it can be disaster. So tadalafil 5 milligrams once daily. Second, wrong dose or dosing pattern. Now this occurs when the dosage calculation or schedule is wrong. Like wrong calculation of pediatric doses or using adult dose in a child. This happens many times. Failure to adopt asymmetric dosing regimen for isosorbide mononitrate. Thousands of prescriptions of isosorbide mononitrate must have come to you. So here you can educate the patient. Even if the patient is, the doctor has written BD, you have to educate the patient. If he takes first dose at 9 o'clock, second dose has to be after 7 hours. So 3 o'clock or 4 o'clock. So second dose should fall within 7 to 8 hours, not BD, not after 12 hours like other drugs, because it follows asymmetric dosing pattern to prevent tolerance. Chloroquine given TDS in Vivax malaria, chloroquine is given in specialized dose. It is 600 milligrams stat followed by 300 milligrams after 6 hours, 300 milligrams once daily for next 2 days. This is the pattern of chloroquine dose. So giving TDS in Vivax malaria again is wrong. Again, acyclovir 400 milligrams TDS for chickenpox is wrong. For chickenpox, acyclovir is given 4 times daily. It's one condition where acyclovir is given 4 times daily. Otherwise, for all other indications, it is given 5 times daily. The dose here for chickenpox is 800 milligrams 4 times daily. I have seen consultant physicians giving 400 milligrams TDS for chickenpox. It is wrong dose. The chickenpox does not get cured and patient goes into neuritis later on, especially if this is prescribed for herpes zoster also in similar dose, then patient can go into very severe complications. Then sudden withdrawal of corticosteroids after high dose and prolonged therapy. This can be disastrous. If the patient comes to you repeatedly with corticosteroid prescription and suddenly the patient withdraws, or you now realize that a doctor has stopped suddenly, then you can educate the patient. It has to be slowly withdrawn. Abrupt withdrawal can cause very high degree of complications. Depoxetin given TDS or just before coitus for premature ejaculation again is wrong. It has to be given 30 minutes before coitus. Next one is very, very common. Using glimepiride 1 milligrams in the morning and 2 milligrams in the afternoon. This is wrong habit. I've seen many prescriptions with this type of prescribing. If at all you want to give glimepiride 1 milligram in the morning and again 2 milligrams later, it has to be in the evening before dinner and not morning and afternoon. Rabiprazole, or for that matter, any proton pump inhibitor, omeprazole, rabiprazole, esomeprazole, lansoprazole, all these have to be given 1 hour before breakfast. Because they are proton pump inhibitors, they act by blocking or inhibiting the proton pump, which is active on empty stomach. So there is no point in prescribing rabiprazole, BD or TDS. TDS, there is no proton pump available in the afternoon or evening, so there is no point in prescribing rabiprazole, BD or TDS. So these are the points where you have to keep in mind. Kinetic errors, third one. These are very interesting errors. This can actually cause failure of therapy. If these errors are picked up, then you will be of great help. Giving iron salts on full stomach. Please remember, iron salts availability is decreased on full stomach. But they have to be not to be given empty stomach also. Empty stomach, they can cause gastritis. So the correct time for iron salts is 1 hour after lunch. Best time for giving iron salts, 1 hour after lunch. So please remember, if anybody comes to you with a prescription having iron salts, even if the doctor has told him, or rather her, in pregnancy, this is a common mistake in pregnancy, iron salts have to be given 1 hour after lunch. Then advising PPI at any time of the day, I already said it, or after meals, it has to be given, proton pump inhibitor has to be given on empty stomach 1 hour before tea. Third one is very, very common. You will agree with me. Prescribing enteric coated aspirin after lunch or with H2 blockers or proton pump inhibitors. This is common habit. People prescribe ecosprin 75, ecosprin 150 or 325 after lunch. And along with that, we have tablet ranitidine, Entec, or capsule pen 40, pantoprazole. Now, what happens in this case? Enteric coated aspirin, if you give it after lunch, the coating will dissolve. After lunch, the pH is alkaline, and the enteric coating has to be dissolved in alkaline medium in the intestine. That's why the coating is enteric. Because we do not want aspirin to be dissolved in stomach, because it can cause severe gastritis. So this enteric coating has to be dissolved in intestine. So you give it 45 minutes before lunch. So when you give ecosprin 45 minutes before lunch, it nicely travels to small intestine, and the coating dissolves in alkaline medium of the small intestine. But if you give it after lunch, when the medium is alkaline, the coating will dissolve in the stomach itself. There's no point in giving enteric coating. So you are creating problems for the patient. And when you give it along with H2 blockers and proton pump inhibitors, absorption of aspirin is further hampered. So this is a very good place where pharmacist can actually help the patient and explain to him that enteric coated aspirin has to be taken 45 minutes before lunch. They're not giving ampicillin, azithromycin on empty stomach. We'll come to many other examples of food-drug interactions later in the talk. But just to add, azithromycin, ampicillin should be given on empty stomach. Next, injecting insulin in different anatomic regions to rotate sites. Now, this is, you have to educate the patients. When we teach pharmacology in anti-diabetics, we tell them injection insulin, the sites have to be rotated. Now, what is the meaning of that? The sites have to be rotated means you cannot inject at the same site every day. So that does not mean you inject around the umbilicus on first day, or thigh on the second day, or buttock on the third day, or somebody else's buttock on the fourth day. It is not so. It is not rotating like this. Rotation should be in the same anatomic region. Like if you are taking insulin on the thigh, thigh is a very big area, you take insulin on different portions of the thigh. Or if you are taking around the umbilicus, take it at different region of the umbilicus every day. But don't change from umbilicus to thigh. So here you can educate the patient, because patients do not know. They are not being told by the doctor. So please educate the patient. Injecting insulin in different anatomic regions can cause problem in absorption. Injecting insulin aspart and lispro 30 to 45 minutes before meals. No, it is not regular insulin. Regular insulin, yes, 30 to 45 minutes before meals. Aspart and lispro are fast acting analogs, rapid acting analogs. So you have to take them 5 minutes before meals. If you take 30 to 45 minutes before meals, there is every chance that a patient will go into hypoglycemia and can fall with decrease in sugar. Not advising patients to take acarbose and voglibose at the first bite of each meal. Again, a common mistake in practice. Acarbose, voglibose is a drug, has to be taken at first bite of each meal. This drug has to be taken and you have to start eating. You cannot wait for the action. It has to be taken just before the meals. Next one is a very, very commonly done error, prescribing albendazole after dinner for worm infestation. All the doctors tell the patient, take albendazole after dinner. Absolutely wrong. After dinner, albendazole will be very nicely absorbed in the circulation. We don't want albendazole to be absorbed in the circulation. We want albendazole to act on the intestine where worms are residing. So you have to take it 1 hour before dinner so that it does not get absorbed. You do not want albendazole to get absorbed for helminthiasis. But for cysticercosis, yes, where albendazole has to reach the brain for cysticercosis, there it has to be taken after meals. But for helminthiasis, for worm infestation, it has to be taken 1 hour before dinner. Retard tablets, SR tablets, never to be given TDS, either OD or BD. Never half. You cannot half a retard tablet. And thyroxine after breakfast is again a disastrous prescribing. Thyroxine has to be taken almost 2 hours before breakfast. If not 2 hours, at least 1.5 hours. Nothing should come between thyroxine because thyroxine is a very, very dangerous drug. It interacts with almost everything. It has to be taken alone. So these are very, very important kinetic errors, and you can definitely help in the capacity of a pharmacist. Now, combination errors, the last part of a prescribing error, combining drugs wrongly. Like starting 2 or more drugs as first line in epilepsies, prescribing co-amoxiclav in a lady on oral contraceptives. Now, this is a very dangerous situation. You can imagine a newly married lady on oral contraceptives who does not want a baby and comes with a respiratory tract infection to you. And if you dispense co-amoxiclav or a patient is a doctor has prescribed co-amoxiclav, then co-amoxiclav can metabolize oral contraceptives very rapidly. So there can be failure of oral contraceptives and she will become pregnant. And she will blame you that you have made her pregnant. And the judge will not understand what exactly happened. So these are common things to be picked up. Advising co-ingestion of iron and calcium, pregnancy, where iron and calcium are given together. Patients are not told when to take calcium after breakfast, iron, as I said, 1 hour after lunch. Please remember, calcium after breakfast, iron 1 hour after lunch. Beta-histine, cinnarizine in vertigo, even ENT specialists make this mistake. Both are useful in vertigo, but both cannot be used together because one competes with the other and both do not have any action. So beta-histine is agonist, cinnarizine is antagonist. Both are useful in vertigo, but together they have no action. Propranolol, verapamil together can decrease heart rate. Antacids with ciprofloxacin, absorption of ciprofloxacin will be reduced. Iron salts with thyroxine, quinolones, again absorption will be reduced. So these prescriptions in combination can cause a problem. Using tablets and syrups with same composition, using zinc salts with quinolones, taking ginkgo biloba with aspirin, warfarin, NSAIDs. People like to prescribe tonics containing ginkgo biloba, but they can interfere with your main drugs. Prescribing phenytoin with vitamin B6 containing preparations, or using calcium in patients put on ofloxacin tetracyclines. Calcium with amlodipine. Amlodipine is calcium channel blocker. So if you take calcium along with amlodipine, then amlodipine action will go down. Prescribing loperamide and antibacterials for dysentery. Please note this. Dysentery is a bacterial condition, Shigella dysentery or amoebic dysentery, where a specific antibiotic has to be used. But if you use loperamide, which is motility inhibitor, then you are decreasing the motility of the gut. Diarrhea will decrease, but the infections will remain in the body. The bacteria will remain in the body because they have to be washed out. Bacteria will remain in the body and can cause toxic syndrome. So never dispense loperamide without understanding the condition. Many pharmacies do that. They're using 2 or more antibacterials with similar spectrum, like amikacin, estronam. Both are having gram-negative action. So combining this can be a problem. Now, using wrong and irrational apheresis, this is just for the information. There are so many fixed dose combinations which are wrong. If doctor has prescribed this, I don't think you can do much here, but there are some areas where you can definitely help. Amoxicillin, ampicillin with fluoxacillin is wrong. Paracetamol in combination, NSAIDs is wrong. Cefixime plus azithromycin, no role. Quinolones with metronidazole, tinidazole for diarrhea is wrong. ACE inhibitors with ARBs is totally wrong. Levocetrizine, montelukast and ambroxol. Domperidone, ondansetron with H2 blockers and proton pump inhibitors. Again, wrong combination. Ranitidine with dicyclomine, ambroxol, carbocysteine, bromhexine with ciprofloxacin, amoxicillin, ceftriaxone, codeine, noscapine, ammonium chloride, phenylephrine, ambroxol, all together. One is a suppressant, one is an expectorant, one is a mucolytic, so nothing works. Cough remains as it is. Glimepiride, metformin, voglibose combination is rampantly prescribed. Glimepiride to be used 10 minutes before, metformin after, voglibose first bite. So how are you going to do this combination? At what time? So nothing works adequately. Things will work, but patients will not get the benefit of all three adequately. Rabeprazole with aceclofenac, diclofenac, trypsin, chymotrypsin, again, wrong combination. Trypsin, chymotrypsin are enzymes to be given on empty stomach. Diclofenac has to be given on full stomach, so you cannot possibly combine this. It's one FD. Diclofenac with serratiopeptidase. Serratiopeptidase is the most useless drug. It only adds to the cost. Wrong combination. It does nothing to inflammation. It's just like a lion going with rat for hunting. Rat has no role to play when lion is there. It is just a cosmetic value. Similarly, when diclofenac anti-inflammatory is there, cerasorpeptidase has no role to play. It does nothing to inflammation. So these are some hand-picked fixed dose combinations. There are hundreds of them, just for your knowledge. So that is about the errors. Now, the second important thing, we'll rapidly go through look-alike, sound-alike drug brands. This is a 1 hour lecture by itself. But I've just picked salient features of look-alike, sound-alike drug brands because you come across this every day in the pharmacy. As you know, prescribing drugs with a brand name is an essential part of medical practice, but there is so much plethora of branded formulations, and it has great potential for creating confusion among the doctors, pharmacists, and patients. Plus, there is illegible handwriting which nobody can read, and one drug can look like the other drug on prescription, and you can commit a disastrous error. So slight deviation of legibility can cause serious damage. Look at this, dispensing saline instead of Celib to a patient with arthritis, or taking Tobitil, tinoxicam in place of Tibitol, ethambutol. Imagine, Tibitol is prescribed, that is ethambutol, to make his tuberculosis disappear, but here if you dispense Tobitil, tinoxicam, which is a very highly potent anti-inflammatory, his tuberculosis will never disappear, but his stomach will disappear because of gastritis when you prescribe Tobitil for 9 months, because the prescription will be for 9 months. So you have to be very careful where these sound-alike, look-alike names are there in your the prescription. So these Lassa or Sala drugs, these are strikingly similar in physical appearance or packaging, and those they have similar sound and or similar spellings. So they can be identical or orthographic, having similar spellings, or phonological, similar sounding. So what is the source of error? The main reasons for improper dispensing of confusing brand names may be due to negligence or lack of knowledge of pharmacists, or due to less number of pharmacists during rush hours. So be careful during rush hours. This is the time when you commit most of the mistakes. When brand names or 2 or more drugs are similar, faulty dispensing would result from one of the following situations: either illegible handwriting, or incorrect dispensing due to oversight, or incorrect understanding of the brand name by the patient while taking the order on phone. If the patient has taken order on phone, he will understand differently, and when he tells you the name, it will be third name with similar sound. So these are the areas where errors can occur. So these are the common risk factors associated with look-alike, sound-alike medications: illegible handwriting, incomplete knowledge of drug names, newly available products, similar packaging or labeling, similar strengths, similar use, and dispensing on verbal requests. Just some examples of confusion: Lasix and Lennox, one is furosemide, other is diclofenac, Intex, Allegra, Edigra. Remember, you can imagine a patient comes to the pharmacy and asks for Allegra for his allergy, fexofenadine, and somebody in that busy pharmacy hears Edigra and gives sildenafil. What will happen to him? His allergy will never disappear, but it will come at a wrong place. So Allegra and Edigra, Izordil, Plendil, Emaril, Reminil, one is anti-diabetic, other is anti-dementia, Loran, anti-hypertensive, anti-cold, Ambisome, Ambifom, Lomotil, Lomtin, Antibin, Antiban, very dangerous, Antibin and Antiban, Lexin, very, very similar. One is anti-ulcer, can be given for 4 to 6 weeks. Second is aminoglycoside, maybe for a few days. Anti-DEP, anti-LEP, imipramine, carbamazepine, microcid, Aracid, Arabid, Milcolec, Micronec, Estin, Estalin, Mitolar, Mitopar. So there are hundreds of such names which can be very similar looking and similar sounding. There is no end to this. Dioval, Diovan, Trima, Trimo. And look at this: Valance, Balance, Balance. One is anti-epileptic, second is anti-vertigo, and third is anti-ulcer. So please be careful when you dispense. Be careful of these look-alike, sound-alike names and similar looking packaging. You know, some pharmacies have the habit of putting medicines of one company together, and that itself can be problematic. Instead of that, I would advise put one drug together. Because if you put one company together, there might be similar looking packaging for that company, because companies like to have similar packages. Look at that: propylthiouracil colchicine, naloxone verapamil, hydralazine hydroxyzine. So heparin midazolam, very similar looking packages, very, very similar looking. So one can be given for the other, and this can be a disaster, especially if it is injection. Look at this: 3 eye drops from the same company, all 3 are different, but same packaging. If you do not read the name properly, all 3 are different. And insulins, names of insulins are so much similar: Actrapid HM, human mixtard, mixtard HM. So if you look at just HM, you may give mixtard HM for Actrapid HM, and so on and so forth. And as I said, Tibitol, Tobitil. And look at this: Mahaquin, moxifloxacin can be confused with Malaquin, that is chloroquine. It could be confused with Maxoquin, which is Mefloquine. And Mefloquine is also Mefmal. And this Mefmal, if somebody comes with Mefmal, you may give him Meftal, which is mefenamic acid, and so forth. And many companies, especially antihypertensive range, they have similar names. Even the doctor will not know what exactly is prescribing. Telmikind range: Telmikind Trio, Telmikind 80, Telmikind 40, Telmikind AMH, Telmikind H80, Telmikind CT40, Telmikind 40, 20, Beta 50. Even the doctor may not be knowing what exactly is there in the Telmikind. So this pharmacy, instead of AM may look like H, or AM may look like AMH. So you may dispense AMH in place of AM, or AM in place of AMH. So there can be a lot of confusion because each combination is different with similar broad name. And GRA sound, I already told you, if somebody has prescribed Allegra or asking for Allegra, and if you give Etgra or Malegra or Tadagra, they are totally different compounds. 3D are not the same. Amlosef 3D, I've seen one pharmacy where dispensed, instead of Amlosef 3D, which I had prescribed, the patient came back to me saying the Amlosef 3D is not available in the pharmacy has given Levois 3D. Amlosef 3D is for hypertension, 3 drugs together, whereas Levois 3D is abscepropylhylin, montelukast, and fexofenadine for allergy. Look at this. Just looking at 3D doesn't make the medicine same. And this is another dangerous thing. Inter-country names can differ. If a foreigner comes to you and asks for Zolex, Zolex in his country will be fluconazole. So there is every likelihood you will give Zolex available in your pharmacy, which is alprazolam. And I know one patient who was prescribed Zolex in India, and he was given Colex. Colex is sodium picosulfate for constipation. So instead of sleeping, he must have gone 1,000 times in the toilet. And look at this: Roxin in one country is ciprofloxacin, whereas in India it is azithromycin, it is roxithromycin, it is pyroxin, is cefuroxim, and it can be confused with droxin also, which is hydroxyzin. So similar looking names, same sounds, especially inter-country. So when a foreigner comes to you, or an Indian who has come from abroad comes to you saying that this has been prescribed to me abroad, please verify what exactly he was taking. Don't go just by name, because the names may be different in different countries. And Reglan, somebody might have prescribed Reglan, you may give Reglin 0.5, or somebody might have prescribed Reglin 0.5 for diabetes and you give Relgin 0.5, which is very, very similar, just interchange of alphabets. Relgin 0.5 is Rasagilin for Parkinsonism. Very, very high chance of dispensing Reglin for Relgin. Same dose, same alphabets, only LG and GL. And can you confuse this? Candiforce, Moxiforce, Manforce, all from mankind. So if you are keeping drugs of one company together, Manforce can be given in place of Moxiforce, and he will increase his force instead of taking care of his infection without giving Moxiforce. So please be careful. And thyroxine, Thyrocab is carbimazole, exactly opposite. And a doctor may feel Thyrocut from the name is also carbimazole. I've seen a prescription where doctor had prescribed Thyrocut 25 for hyperthyroidism, thinking it is thyroid, thinking it is carbimazole. So please verify if the patient has high thyroid or low thyroid, doctor himself may be confused with the name. This is totally misleading name, thyrocut, as if you are cutting thyroid. It is actually thyroxine, where you are increasing the thyroid level. So these are some misleading names. Thyroxine can be Fertibex also. So if you get a prescription of Fertibex 50 and that is not available in a pharmacy, there's high chance you may think it is clomiphene citrate, which is Fertomid 50. Very, very high chance. Fertibex 50 has nothing to do with fertility. It is thyroxine 50. Whereas Fertomid 50 is clomiphene citrate for inducing ovulation. Same dose. And look at this Medzol. Medzol 40 is esomeprazole, 400 is albendazole, 200 is itraconazole, VAT is febendazole, suspension is metronidazole, RD is something else, DSR and D, all are different with just same name Medzol. And these are the names in front of you. Medzol 40, if somebody instead of writing 400 writes 40, then it can be disastrous. So, what is the message to the pharmacist? Pharmacist should be wholly convinced about the nature of the brand they are dispensing. If there is a doubt, they should not hesitate to consult a doctor or their colleague. It is always desirable for the pharmacist to have knowledge of the doses of the commonly used drugs. At least there you can find out from the dose that maybe the doctor is meaning this. And it is observed that many times they dispense the brands available at the shop rather than what is prescribed. So please do not give something that is available at your pharmacy. Just clarify what exactly the doctor has prescribed. So store LASA medications separately from LASA pairs. This is one important advice I would give you. Use additional warning labels for LASA pairs. Check appropriateness of the dose for the drug prescribed, and highlight similarity in appearance to patients while dispensing. So that is about look-alike, sound-alike drugs. Now, third important thing, drug interactions. So we'll rapidly go through drug interaction. I know it is very, very vast topic, but I've just put few common drug interactions that can occur and you can help the patient. So drug interaction occurs when effects of a drug are changed by the presence of another drug, herbal medicine, food, drink, or by some environmental chemical agent. So it can be beneficial, it can be harmful, it can neutralize the effect, like beta-histine and synergism that I've said, and it can be opposite effect. So two drugs may not be beneficial at all times. They can be harmful, they can have no effect, and they can actually have contradictory effect. So drug interactions are an avoidable cause of patient harm, and pharmacists can look into possible drug interactions before dispensing. So there can be drug-drug interactions, there can be drug-food interactions, and there can be drug-herb interactions. Two main interactions are kinetic and dynamic. So kinetic drug interactions occurs by processes like absorption, distribution, metabolism, and excretion. So they can occur at these particular sites. So some examples of kinetic interactions where you can play a role. Antacids decrease absorption of ciprofloxacin and tetracycline. So if you get a prescription where antacids are prescribed along with ciprofloxacin or tetracyclines, you explain to the patient that this is wrong and convince the patient and don't prescribe. Iron, calcium, antacids decrease the absorption of fluoroquinolones and tetracyclines. Don't prescribe them together. Concurrent administration of bisphosphonates and calcium decrease absorption of both. This is common mistake by orthopedic physicians, orthopedic surgeons. They, for osteoarthritis or decreased calcium, they prescribe both zoledronic acid or alendronic acid, that is bisphosphonate, along with calcium. But if you prescribe bisphosphonates, that is alendronate, zoledronate, telludronate, along with calcium, then they are antagonistic to each other. Then enzyme inducers like phenytoin, carbamazepine, rifampicin, they decrease the effect of oral hypoglycemics, oral anticoagulants, and oral contraceptives. If the patient is on oral hypoglycemics, oral anticoagulants like warfarin or oral contraceptives, and simultaneously the doctor has written phenytoin or carbamazepine, then you have to be really vigilant and explain to the patient. You may tell the doctor also, there's no harm in telling the doctor. You can say, don't say you are wrong. You always say, sir, I feel there's a drug interaction between carbamazepine and your glimepiride. So please check. So there's always a way to explain to the doctor. Coming to dynamic interactions, They occur when interacting drugs have similar either additive effects or they have opposing effects at the same system, like antagonism of hypoglycemic agents by corticosteroids. Corticosteroids increase blood sugar. So if the patient receives hypoglycemic agents and he also receives high dose of corticosteroids, then the action will be nullified. Levodopa effect is opposed by antipsychotics. Sinarezine, betahistine given together, I already told you, both are antagonistic. Lithium toxicity can be precipitated by diuretics and antagonism of antihypertensives and diuretics by NSAIDs. So these are just tip of the iceberg drug interaction, just to make you aware there are thousands of drug interactions and you cannot be possibly expected to pick them up. No doctor can actually remember all drug interactions. But if the patient has come with a prescription having 10 drugs, then please observe. See if you can spot something very striking, like sinarezine, betahistine, or hypoglycemic agent with corticosteroid, propranolol, verapamil together. So if you can see something striking, then you can possibly be a very good counselor and you can help the patient. Then drug-food interactions. This is where you can definitely help the patient. Bioavailability increased by food. So these drugs, if the patient is put on any one of these drugs, you can always tell the doctor, I mean tell the patient that you have to take this on full stomach because doctor might not have told. Cefuroxime-axetil, cefpodoxime-proxetil, chloroquine, metoprolol, doxycycline, carbamazepine, phenytoin, itraconazole, lithium, fenofibrate, allopurinol. These are common drugs where bioavailability is increased by food, so they have to be taken on full stomach. So please counsel the patients to take this on full stomach. Bioavailability decreased by food, so ampicillin, azithromycin, L-dopa, rifampicin, norfloxacin, ofloxacin, digoxin, alendronate, thyroxine, these have to be taken strictly on empty stomach, very strictly on empty stomach. Azithromycin, common mistake. Albendazole, common mistake. So they have to be taken on empty stomach. So please help the patients, explain to them how the drug has to be taken. Albendazole, fulminanthiasis before meals. I already told you. Iron salts 1 hour after meals. Cabbage and broccoli can induce enzymes. So if the patient is on certain drugs like warfarin sodium, cardiac drugs, tell the patient not to have cabbage or broccoli in their diet. They can induce enzymes and wash out warfarin. Garlic, onion, potentiate antihypertensive. So hypertensive patient, you can always advise to have garlic and onion. Grapefruit juice can inhibit enzymes and can throw most of the drugs in dustbin. So grapefruit juice should be avoided when the patient is on multiple medications. You can always help the patient in telling this. Some vegetables like broccoli, parsley, spinach are high in vitamin K, and eating large quantities of making sudden changes in amounts eaten of these vegetables can interfere with effectiveness and safety of warfarin therapy. So if you have a lot of broccoli, a lot of parsley or spinach, then vitamin K levels will go high, and vitamin K is an antidote to warfarin. If levels of warfarin go high, then we give vitamin K. So if you eat vegetables high in vitamin K, then food interaction can take place. Similarly, oxalic acids like fenugreek, spinach, dairy products, phosphorus is high, cereals, phytic acid, they decrease calcium and iron absorption. So this, especially a lot of mothers and mother-in-laws advise their daughters and daughters-in-law pregnancy to have a lot of spinach, a lot of fenugreek. Here, this is the catch point. Fenugreek contains oxalic acid, which decreases your vital calcium and iron. So all those efforts of mother-in-laws and mothers go waste. So I've been trying to educate doctors also, and in our pharmacy programs, oxalic acid containing food should be avoided when calcium and iron has to be taken. So please tell the patient, pregnant patients, not to take methi, warchi bhaji, spinach, because they contain oxalic acid, which will decrease your calcium and iron. This is a very, very important practical point. Avoid excessive potassium intake. Bananas, oranges, potassium supplements. Bananas and oranges especially high in potassium. If you are taking telmisartan, then spironolactone, the high potassium can decrease the effect of your telmikind, telmisartan, or your enalapril, rather, enalapril, lisinopril, ACE inhibitors. So effect of ACE inhibitors can decrease if you take foods which are excessive in potassium, like enalapril, lisinopril, ramipril. Eating or drinking foods and beverages that contain coffee, caffeine, chocolates, colas, coffee and tea while taking theophylline for asthma increases the risk of drug toxicity. So if the patient comes with the prescription of theophylline, advise him not to take coffee or tea, maybe just 1 cup. Okay, he can take theophylline, sustained release at bedtime, have coffee in the morning. It may not interfere, but having a lot of coffees, people take 5-6 cups of coffee, then it will increase the risk of theophylline toxicity. Drug-herb interactions, just to give you one example, phenytoin with Shankhapushpi. I know one patient who was on phenytoin for epilepsy. Suddenly he went to the pharmacy and took Shankhapushpi to improve his memory, and levels of phenytoin went down and he had severe episode of epilepsy. So routine drug history is very, very important for us. Never ever dispense Ayurvedic medicines when the patient is on allopathic medicines, unless you know 100% it will not interfere. Ginkgo biloba can cause bleeding when combined with warfarin or aspirin. Ginkgo biloba can raise blood pressure when combined with thiazides. Ginseng containing tonics can reduce blood concentrations of warfarin. There are a few examples where we have actually seen this in research, that some tonics containing ginkgo or ginseng can interfere with regular drugs. These are the vulnerable patients: elderly, patients with liver disease, patients with unstable disease, transplant patients, or patients who have more than one prescribing doctor. The patient may have a physician, he may have an orthopedic surgeon, he may have a gynecologist, or she may have a gynecologist. There are so many prescriptions, he may have a geriatrician. So there are so many doctors prescribing to one patient, and there might be 4 or 5 prescriptions together. Each doctor does not know what the other has done. So here you have a role to play. See what the patient actually takes, especially if it is an elderly patient. This is a clinical classification. Category X, you have to avoid totally tramadol plus carbamazepine, benzodiazepine, olanzapine, amiodarone, ondansetron, propranolol, verapamil. Just to give a few examples, especially tramadol and carbamazepine. Clopidogrel, pantoprazole. This is something very, very common. Whenever a doctor prescribes clopidogrel for heart condition, he invariably prescribes PAN40, pantoprazole. You will agree with me. But PAN40 can decrease the effect of clopidogrel. So this heart patient, poor fellow, does not get the benefit of clopidogrel, whereas he gets pantoprazole unnecessarily. Iron and calcium, I already told you. Allopurinol and calcium. So these are some examples where 2 drugs together can cause interference in action. Thyroxine and iron, corticosteroids and antacids. So here, if you know these examples, you can help the patient to some extent. These are some combinations where you have to just observe. Nothing dangerous, antihypertensive combinations or iron salts and proton inhibitors. They are just for completion's sake, you have to observe the patients. So who is at greater risk? Patient taking 2 or more drugs, person using prescription and over-the-counter drugs together, persons not following drug directions, persons taking drugs for long periods of time, and persons who drink alcohol excessively. Alcohol is one compound which can decrease the effect of drug. So you have to explain to the patient to abstain from alcohol when he is on important drugs. So how to lower the risk of drug-nutrient interactions? Tell your physician all the drugs you are taking, and the patient has to keep a list of all the drugs. Discuss with the pharmacist, and pharmacists can guide multi-drug prescriptions very effectively. So you should have knowledge to do that. Lastly, now that you are happy, you have seen drug interactions, you have seen prescription errors, you have seen look-alike, sound-alike drugs. Now to dispense, can you go wrong? Yes, you can as well commit a dispensing error. So it is defined as a deviation from an interpretable written prescription or a medication error order, including written modifications to the prescription made by a pharmacist following contact with the prescriber. So you are dispensing something which the doctor has not written, as simple as that. So there are 2 types of errors: mechanical error, which includes dispensing the wrong drug, dosage form, directions, quantity or strength, or a judgmental error, which includes improper or no counseling. Please understand, counseling is a part of dispensing. Abbott's pharmacist errors says counseling is a part of dispensing. If you do not do counseling, or if it is improper counseling, it becomes a judgmental error. Failure to detect drug interactions becomes a judgmental error. So you have to be well versed with drug interactions, with prescription errors before dispensing a drug. Otherwise, you are committing a judgmental error. Why worry? Because if you are in addition to causing serious morbidity and mortality, dispensing errors increase economic burden. It can lead to litigation, and definitely it will be traumatic for the pharmacist as well as the patient. So these are the types of dispensing errors very quickly. Drug content errors, wrong drug dispensed, wrong strength dispensed, wrong form dispensed, wrong quantity dispensed, expired or deteriorated drug dispensed. If you are keeping drugs in the pharmacy for years together, suddenly you get a prescription, it might be expired or deteriorated. Failure to supply a drug also is a dispensing error if you are having it in your pharmacy. Issue errors, issued to wrong patient or incorrectly bagged. So that is that documentation. This is the right documentation when I said one of the 8 rights. So you have to see that you have documented it correctly. If you are bagging it, putting in the bag, 2 drugs in 2 bags, see that you write the name of the drug correctly. So incorrectly bagged becomes an issue error. Labeling errors, again, wrong drug name while writing, wrong strength, wrong dosage form, wrong directions, wrong patient's name. So do not collect 3-4 prescriptions together. You may interfere with the patient. Wrong quantity on label, wrong word, and completely wrong labels. All these are so many labeling errors which you could commit. So what are the factors contributing to dispensing errors? Workload, similar drug names, similar packaging, staffing levels. If there's only one pharmacist in a busy pharmacy, poor handwriting, interruptions, distractions, phone from your girlfriend. You'll be more interested in listening to her rather than dispensing. Design of dispensary. If it is crowded dispensary, then you may have less time, less space. Staff inexperience, ambiguous directions by the doctor, failure to check and recheck, job dissatisfaction. You are not interested in your job. Just because you have no job, you have joined the pharmacy. So you are not actually happy. But you are dispensing. So there also you can commit an error. Poor communication, computer software, you have typed wrongly, noise in the pharmacy. So sound alike drug, you may dispense. Proximity of drugs on shelves. 2 look-alike drugs, if you keep together, then you can as well dispense a wrong one. No breaks, hunger, fatigue, stress. Failure to follow standard operating procedures. Lack of training, lack of concentration, lighting, complex prescription, and lack of knowledge. Look at the prescription on the right-hand side. Very difficult to understand handwriting. So such complex prescriptions lead to errors. Injectables, these are most dangerous, higher potential for causing severe damage. So when you're dispensing an injectable, I've shown you so many similar looking injectables, especially eye drops plus injectables, very, very similar looking package. So be careful when you dispense an injectable. So what are the 10 strategies for minimizing dispensing errors? Ensure correct entry of the prescription. Confirm that the prescription is correct and complete. Be careful with zeros and abbreviations. Beware of look-alike and sound-alike drugs. Organize the workplace properly. Reduce distractions when possible. Focus on reducing stress and balancing heavy workloads. Thoroughly check all prescriptions. Take the time to store the drugs properly. And always provide thorough patient counseling. The last one is the most important because now you are no longer only a dispenser, you are a patient counselor also. So guidelines to pharmacists to recommend and recognize appropriate drug therapy. Pharmacists should stay abreast of the current state of knowledge. Pharmacists should never assume or guess the intent of confusing medication orders. If there are any questions, the prescriber should be contacted prior to dispensing. They should check that they are dispensing the right drugs in the prescribed dosage to the right person. They should never dispense without a new return valid prescription. New return valid. See the date. He cannot bring a prescription from 1964. For that matter, even 2021 January cannot be brought now. So it has to be a new return valid prescription. There are legal issues. Actions may result in penalties, including suspension or revocation of pharmacist license. So it may be a part of human nature to err, but it is also part of human nature to create solutions, find better alternatives, and meet the challenges ahead. So pharmacists must be up to the challenge, and I'm sure all of you will be up to the challenge and do very sincere and rational dispensing. So tell your patients, I just want to make you happy because you are the reason that I am so happy. Very beautiful quote. I just want to make you happy because you are the reason that I am so happy. You are for the patient. Believe in yourselves. If you can believe it, the mind can achieve it. Ronnie Lott's very beautiful statement. If you can believe it, the mind can achieve it. Believe in yourselves. Move from yesterday's pharmacist, who was just a dispenser or maker of medicines, to today's pharmacist, who is a counselor and a caregiver. So I end by saying this: what we receive is information, what we preserve is knowledge, what we use is intelligence, but what, when, and how we use it is our wisdom. So, final message: do everything with wisdom. You should gather information, use your knowledge, use your intelligence, but ultimately use your wisdom. Do a good prescription audit. Look at the prescription errors. Look at sound-alike, look-alike names. Look at drug interactions and dispense correctly without any errors. So thank you. Best wishes for a rational and an error-free dispensing. Thank you very much.
Thank you, sir. So thanks a lot, sir, for your wonderful webinar and giving us very important information regarding the prescription analysis and audit, and with, I should say, lots of examples. So with this only, we have received so many comments in the chat box with the opinion of the participants, as it was a very nice and informative session. So many people have commented. Congratulations, sir, and thank you again. And over here now, moving ahead with the question and answer session. I would like to go ahead with the first question.
Can you hear me? Can you hear me?
Yes, sir. Yes.
Okay.
So going ahead now with the first question, that here you have given so many examples, okay, which can be maybe analyzed by the pharmacist. So to maybe to do a thorough analysis of any prescription, lot much knowledge is required about the drugs and therapy. Okay, so what do you think, how to train the pharmacist with this particular respect? Because it is not so easy to gather.
It is not, yes, I agree. It is not easy. In fact, the best way to train them is have continue pharmacy education programs very effectively, as we are doing in Goa. Every 3 months, we are having a continued pharmacy education program to educate the pharmacists. We select important issues, important topics which are of value and use to them. And I'm happy many of my pharmacists have actually benefited, and they're helping their patients in Goa with their knowledge. But having said that, each pharmacist should take interest, should read themselves, and be familiar with the drugs, their doses, as I said, and maybe make a list of P drugs, personal drugs, most commonly used or dispensed drugs in their pharmacy. There might be some pharmacies which are very close to one doctor, and doctor may be used to prescribing only those. So it's a very good idea to know more about those drugs and store them in the pharmacy. But in big pharmacies, you have to tell your pharmacists, be vigilant, read the pharmacy matter, read pharmacology every day, and be familiar with the drugs. Only then you can improve yourself. There's no other way, no shortcuts.
Okay, so next thing, what I wanted to ask is, whenever we see that there is some error in the prescription, okay, normally it is advised that we have to go back to the physician, and we should ask maybe for the replacement of the drug, or we should inform him regarding possible problem what can happen. Okay, but normally the physicians are also occupied and pharmacists are also many. Okay, so how to create, or what is the way of liaison between the pharmacist and physicians, you think? How they can better communicate?
In fact, what I would say, when a pharmacist puts a pharmacy, he should always keep liaison with the doctor. There should be friendly atmosphere with him and the doctor. They should be friends right in the beginning. So when there are friends, when there is friendly atmosphere between the pharmacist and the doctors, or those few doctors who are going to dispense, who are going to prescribe, then the pharmacist will feel free to ask the doctor if there is a prescription where he finds there is an error. Say, for example, there is a propranolol and verapamil together, cinnarizine and betaine together. He can as well speak to the doctor who is a friend. Even if he is not a friend, you can always say, doctor, I feel cinnarizine and betaine are antagonistic. Just yesterday we had a CPE program and it was told to us it is antagonistic. You can put it that way. You cannot say, "Arey, how are you? What you have prescribed is wrong." No, that is not the way to speak to the doctor. But you can always say, "Doctor, I feel," because just few days back we had a program where we were told that it is antagonistic. Please verify and see that you can change the prescription. Or what do you want me to give? Whether beta-histine or sinalizin? What out of this?
Okay, sir, next, what I want to ask is, in this current pandemic, okay, along with the indicated medicines, the therapeutic and necessary medicines, many people are coming to pharmacies for supplements.
Yes,
Such as
yes.
vitamin C, multivitamins, as well as zinc, okay?
Yes.
So is it safe to dispense them continuously?
No. That's exactly what I said. It will be an indication error, having same medication again and again. So it is not safe to dispense, especially vitamin C can cause stones. It can aggravate the stones. If somebody is having renal stones, it can aggravate by vitamin C. So it is not correct to dispense again and again. So this is where the right response will work. The right that I spoke, right response. If somebody is coming with the same thing again and again, you can always ask why you want this again and again.
Okay. And again, sir, as you rightly spoke about the change in the role of the pharmacist only from the dispenser also to the counseling. So here, apart from the medicines, maybe sometimes patient ask advice, especially in this pandemic, regarding the reuses of the mask. So what we can advise on that behalf?
Regarding reusing of mask,
yeah, maybe N95 you can talk about.
No, same
Washing,
mask to be used,
sanitizing.
washing. See, there are different types of masks. If it is plain cloth mask, which is useless, it does not prevent viral transmission at all. It is just fashion. Now the fashioners come along with the dress, you get a matching mask. That is just a fashion, part of fashion. It does not prevent you at all. Those are washable masks. The correct mask is N95 mask, which gives you protection, which is non-washable. If you wash it, those pores of the mask will be opened and you cannot use it again. But there are some, if at all somebody cannot afford to have these masks, expensive masks, then what you do not scrub them with soap and water. Just wash them and sun dry. That means you are not damaging the pores. Especially N95 mask, you just dip it in water, maybe warm water for some time, maybe 10 minutes, without washing. If you wash with water and scrub, you are damaging the mask. And then sun dry and maybe reuse it. But ideally, N95 mask cannot be, shouldn't be used. If at all, you can use a cloth mask underneath, which is reused, and N95, which is a new one. Maybe for 15 days or so, you can use a N95 mask.
Okay. So the next thing, whichever the examples that you have talked about the irrational combinations, on that few of the participants have asked a few questions we will take. So in this, one participant is saying fixed dose eruption is a side effect of aspirin, and aspirin is a regular drug of the patients. So how to deal with this problem?
Fixed dose eruption, adverse effect.
Yeah.
Adverse effects are very common with aspirin. If the patient has got adverse effect, then he has to report to the doctor. Doctor will have to change the medicine. If at all he is given, say, for cardiac condition, fixed this ecosprin, then he can always have so many antiplatelet drugs available. He can go to clopidogrel. We have seen so many cases where patients are allergic to aspirin. I have seen so many patients. So we change the medicine.
Okay. Next question is Lizoflam tablet is a combination of diclofenac, trypsin, and chymotrypsin.
Yes, it is wrong combination. I already mentioned it.
Yeah, but still it is in market.
Yes, absolutely. All the combinations that I mentioned are in the market, which are wrong. It is a hot drug, hotly prescribed drug. It is wrong. As I said, first of all, that diclofenac cannot be combined with enzymes. Enzymes have to be given strictly on empty stomach. If you are combining trypsin, chymotrypsin, they are destroyed on full stomach. So when you give Lizoflam, which is diclofenac, trypsin, chymotrypsin, and paracetamol, in actual practice, you are giving only diclofenac because trypsin, chymotrypsin will be destroyed. So it is only adds to the cost, does not add to the benefit at all. So instead of that, if at all you want to prescribe trypsin, chymotrypsin, they can be prescribed separately on empty stomach and diclofenac on full stomach rather than fixed dose.
Yeah. So next, they are asking that now with the current trends of the telemedicine and online consultation, okay, how to authentify the prescriptions which are given as telemedicines?
Yes, this is a very, very beautiful question and very difficult to answer. In fact, let me tell you one example where one patient recently had very severe dysentery, bacillary dysentery, and she needed an antibiotic. She went to that WhatsApp app of telemedicine, and I don't know which doctor, but the doctor advised her Lomotil, which are all the examples which I mentioned. Lomotil is loperamide, which is contraindicated in a bacillary dysentery. It will just prevent the stools, it will decrease motility, and it will cause toxic. This was given to me in telemedicine. So telemedicine, I would not advise unless it is really in correct hands. The doctor should really be after the drug, after the patient's history and all that, all those details should be properly sought before giving telemedicine. It can be disastrous.
Okay. Next is nowadays pharmacists are counseling about the guiding maybe information regarding the consumption of the medicine, but still many people don't follow it. The adoption rate is very low.
Yes.
Okay, so in this, how we can improve this particular situation?
Yes, this is a good question. In fact, compliance is low, especially hypertension, diabetes. We see people think they are nice, they are now under control, sugar is under control, but they fail to remember that sugar is under control because of medicine. So they start eating mangoes and chikus and stop the drugs, especially antihypertensives. They stop. I'm feeling better now. The headache has gone. So this is the role of the doctor as well as the pharmacist. Both have to educate the patient to take the medicines lifelong, or till the doctor says that this is not required. They have to take the medicine. This is a difficult task, I agree, but that exactly lies the skill of the pharmacist to counsel. That's why pharmacist has become a counselor. Doctor also has to educate, and pharmacist also, both. The patient has to be educated again and again. Okay, the next question what we are having, that antibiotics nowadays are prescribed in this pandemic. So maybe take an example of the doxycycline, which is having different dosage regimen for the different conditions. So how to decide the dose effectively for this kind of antibiotics, which are multi-indicated? Here, this is the dose. This is the actually dimension of the doctor. For which condition he has prescribed doxycycline, 100 milligrams BD is the standard dose. That is the standard dose for most of the indications. Okay. 200 milligrams day 1, followed by 100 milligrams BD is the standard dose of doxycycline for all indications. There's no other dose for doxycycline. But if somebody has prescribed doxycycline OD, then it is a dosage error. For whatever indication you give, it is 100 milligrams BD. 200 milligrams on day 1, followed by 100 milligrams BD. So if somebody has prescribed other dose than this, then it is a wrong dose. Yeah. So again, other questions are the same, sir, that the fixed dose combinations, whatever you have suggested as will not work properly or will give therapy error are seen in market. So whether to dispense or not. So few examples have given diclofenac and some examples. Yes, classical example is your glimepiride, metformin, and voglibose. Yeah, yeah. So these drugs cannot be, in fact, the sugar will come down, not that it will not come down, but efficiency from 100% will go to 100%, yes. 60% or 70%. If the patient is spending so much and yet he is getting benefit only to the extent of 70%. So rather than that, you prescribe voglibose separately, glimepiride separately, and metformin separately. It may add to the cost, but the benefit is 100%. Yeah, so over here, sir, thank you very much for taking our questions, and thank you participants for actively sending the questions and maybe promoting the knowledge sharing further in this area. So coming to the end of today's session now, I request Dr. Moreshwar Patil, faculty from MIT's Institute of Pharmacy, Nashik, to kindly propose vote of thanks. Patil, sir.
Thank you, madam.
Yeah.
Thank you, Professor Dr. Rataboli, sir. I would like to express my sincere thanks to Rataboli, sir, for spending valuable time with us and giving such a wonderful information regarding auditing of prescription and the errors that may be detrimental to the health of the patient. So we should, as a pharmacist, we should be very careful while handling the prescription. And coming to the end, on the behalf of Western Regional Center, Association of Community Pharmacists of India, I would like to thank Professor Nagappa and Professor Dr. Somani for providing or creating such a nice platform for interaction. I would like to express again sincere thanks to all the participants who have joined this session and contributed to the community pharmacist. So at the end, I would like to say the session is over.
Thank you,
Okay.
sir. Thank
Yeah.
you for giving me opportunity. Thank you
Okay,
very much.
all the participants, thank you, Rataboli sir. All the participants, the information for the upcoming webinar, that is the concluding webinar of WRC-ACPI on 28th of August probably, will be circulated shortly. Kindly make yourselves available for the same, and wishing you all
Thank
a
you,
great
sir.
weekend ahead. Yeah. Okay, thank you.
very much.
Yeah. We
Thank
will
you, Madam
end-
Shilpa.
Yes,
Can I
sir.
take leave?
Yes, sir.
Thank you. Thank you.
Thank you, sir. Thank you, doctor.
Okay.